Hi, my name's Jo Gibson. I was a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit until last week, and I am now an upper limb rehabilitation specialist working at Rehab for Performance in Liverpool and also at a private practice in West Kirby. So it's very lovely to be here tonight to start our Facebook Lives again. Keen to get going, keen to talk about some subjects that might be very useful. Well, obviously, that will be useful to you. So don't forget, if you have any suggestions, make sure you post those on the Clinical Edge page. Now, tonight, I've been talking a lot over the last 2 weeks about the post-op shoulder. So tonight, I'm just see people we've got joining us already. Great to have people there, and nice to see you back. Nice to see you again, Tim, too. Essentially, I've spent a lot of the last 2 weeks talking about post-op shoulders, and I did a webinar last week. And as ever, I always like to update the evidence and have a look at any new papers that are out there. And there certainly actually has been some really nice new evidence looking specifically at outcomes, looking at expectations. And so it was very kind of timely when I was asked to review a patient at the end of last week who'd had an arthroscopic rotator cuff repair for a medium-sized tear. So it was about 2.5, 3 centimeters. This lady was 50. She'd had a fall. It was a traumatic tear. She had a surgery within 12 weeks of falling. And basically, both she and the physiotherapist were very frustrated because she wasn't progressing. She still had a lot of pain and she didn't really feel that she was making any improvement. She was still having significant sleep disturbance at night and generally wasn't very happy. Now, she had been back for a 6-week review with the surgeon. And he just kind of said, carry on. There's no signs of infection. There's nothing I'm worried about. You just need to keep going with your rehab and keep going. So she equally wasn't very happy because she didn't feel that he'd taken much notice of her either. So we've got this lady who's had a traumatic cuff tear. She works as a teacher, clearly not without its stresses during COVID with all the changes and everything. She's got young children, so she's obviously got the balancing act with them as well. She was hoping that obviously they were going to be at school and doing stuff while she was recouping from her surgery, but it sounds like they've been at home more than she thought. Her husband works away, so she's not necessarily had as much support as she liked. She's clearly not sleeping because of the pain of her operation. She doesn't like taking tablets. And it turns out she's also got a pre-existing problem with her cervical spine. So she's just had ongoing problems with stiffness in her neck after a whiplash many years ago. Now, when I go to assess this lady, I'm kind of thinking, well, one, I need to be clearly mindful of the things that can go wrong after rotator cuff surgery and what high levels of pain might warn me about. Now, clearly, she's been seen by one of my surgical colleagues. The physio is very switched on, but I need to be mindful of some key things. Firstly, whether there's any likelihood of infection. And remember, infection, we don't always have overt signs in the early stages that it develops. So we need to remain vigilant. But this lady's got no temperature. She's got no external signs of infection. And in terms of any systemic descriptors, there's an absence of those. Nerve injury, again, can highly correlate with high levels of pain after surgery. Again, I look for any sensory deficits in the most commonly affected nerves. And obviously, in the case of rotator cuff repair, generally your suprascapular nerve. Again, there's no sensory deficits consistent with that. And actually, just doing some gentle testing, she's able to create reasonable power, but with obviously some pain. Clearly, you've got to consider surgical failure, but this lady's pain's been pretty consistently horrible since she had her surgery. She's not had a fall. She's not lifted anything heavy. She's not had a slip or anything like that. So again, because I can create power, obviously because it's very painful, I'd expect it to be weak and painful on long lever testing. And given the number of weeks she is post-op, I want to be a little bit cautious, but I can just unload the arm and bend the elbow. So I'm really taking as much load off the shoulder as possible, get her to make a fist, which just helps her to engage that shoulder a little bit more, and then look at my resisted tests. And certainly her supraspinatus seem to be testing well in that situation. So I'm not worried about failure either. Now, clearly somebody who's 50, who's got a previous history of neck issues, who has a lot of pain post-op, again, that can be an early warning system of somebody developing a frozen shoulder. And so we'd probably have a low threshold to look at other pain relieving modalities if we felt that was an issue. Now, while this lady's got some loss of her external rotation, that's consistent with the surgery that she's had, and it isn't like that severe restriction that we expect to see. But again, it's something we've got to keep an eye on because she's clearly in a risk group for developing that stiffness. Now, what's really interesting One of the key things is obviously what I'm going to ask this lady is what she was expecting from her surgery. And there's absolutely no doubt in terms of rotator cuff surgery, patients have very high expectations. And the good thing is, if they have high expectations, they are actually likely to do better. Where it goes wrong and where there's often a mismatch is the speed of that recovery. So when you ask patients how quickly they think they'll be sleeping through the night and how quickly they think they'll go back to work, it's not always consistent with what the research tells us. So, actually, this is where the research is really helpful. How well should this lady be doing at this stage? Is she doing badly? Or actually, are there things about her history and the story that I've told you that make her likely to be much more slow to respond to our interventions and take longer to get that optimal outcome from her surgery? Well, we're going to look specifically at small and medium arthroscopic rotator cuff tears because this lady had an arthroscopic cuff tear. We can talk another time about the bigger post-op tears because there's probably some other considerations for those. But I've done a kind of updated lit search, if you like, of the current evidence about small and medium arthroscopic repaired tears to help. Let's reflect on this lady and see what we can learn from it and how we could do things differently, or whether we just accept where she's at this stage. So, one of the biggest issues for patients and one of the biggest things that influences their decision to have surgery in the first place is sleep disturbance, a common feature of cuff tears. And that was certainly very instrumental in this lady's decision making. And we know pain's highly correlated with patients' self report of functional level and is also highly correlated with health status. Now, clearly, sleep's always really important for healing, for those growth factors or those psychological factors, cognitive function. So it does matter. Now, you hope that surgery is going to improve that sleep, but how quickly does it improve it? Interestingly, if you look at the studies that have followed patients up, generally it starts to improve around the 4-week mark. And if you think of the inflammatory effects of surgery, that kind of fits very nicely. But in terms of significant improvements, it can actually take as long as 4 months before patients see a significant reduction. If you look at around 3 months, then generally there is about a 50% improvement for patients with no negative prognostic factors. But if you average it out and include those who have got negative prognostic factors, particularly for post-op pain, then as I say, it can be as late as 4 months before they see a significant change. Now, the good news is that about 62% of patients report normal sleep habits at the 6-month mark. So there's a significant improvement between that 3 and 6-month mark. But some 38% of people still have sleep disturbance at 6 months. And it's really important to say that if we do longer term follow ups, actually, some patients are still having low level disturbance, but some level of symptomology, often related to activity, for up to 2 years after their surgery. So, patients expecting to be pain free, we need to be a little bit cautious because actually that's probably unrealistic. Now, most of the studies that have looked at measuring sleep and how it's affected and how much is improved have used the Pittsburgh Sleep Quality Index. Now, a score of 5.5 on that score is generally acceptable for most patients after cuff surgery. Certainly, if you score under 5, that's considered to be a good sleeper. Generally, patients before surgery, the mean reports are a score of around 11. So obviously it does improve quite significantly, but there's a big kind of variation in confidence intervals. Now, some things, and again, what we're thinking with this lady is she's still having issues sleeping through the night. Are there some things that we would know about her preoperatively that make her likely to take longer to get that improvement in her sleep? Now, when you look at the things that do seem to predispose, age, being female, unfortunately, females seem to have a worse time after cuff surgery than men. They have higher levels of pain and they are slower to get better. Cervical spine involvement, 2 or more comorbidities, obesity, diabetes, thyroid. Interestingly, patients who've taken a lot of narcotic or opioid medication preoperatively have worse night pain after, particularly if they continue to take their opioids, which sounds like a bit of a contradiction, but that's well demonstrated in the literature. If they're having revision surgery or if they're on lots of medications for other things. So clearly with this lady, the fact that she's 50, which is a risk group for frozen shoulder, the fact that she's got pre-existing cervical spine issues, and the fact she's female all mean that actually she is going to take longer to see that improvement in her night pain. So at the stage she is post-op, it's probably not unreasonable that she's still having some issues. We need to kind of revisit what she's doing about medication. Now, the other thing that's interesting, I said we were going to talk about small and medium cuff tears, but actually there's no correlation between tear size exercise and sleep. There's one paper that conflicts with that slightly and suggests that smaller partial thickness tears, actually patients have more difficulty getting to sleep and they're more likely to get woken up. But that really conflicts with the other good methodologically sound evidence that's out there. Now, there's been 3 key papers really looking at outcomes in patients with cuff repairs. 2 recently, Cho 2001 and Grubhofer 2021, but also one by Kuriwiki, which is a great group that have done several things looking at outcomes, the effects of comorbidities, but also what we can expect for our patients. So we've talked about night pain, but what about pain generally, and what about range of movement? Well, certainly, if you look at these small and medium arthroscopic, don't know why I can't speak tonight, rotator cuff repairs, at 3 months, you would expect patients to have anywhere between a 50 and 75% improvement in their pain. Now, as I say, when you get to about between 2 and 6 weeks, then generally it can reduce by about a third. But in a female with pre-existing neck problems, remember she's going to be slower. So when we say 50 to 75% at 3 months, this lady's kind of only just getting there, and she is likely to take longer to get to that same level. When we look at functional improvement at 3 months, then it's generally between 45 and 58% in terms of what patients are able to do. But interestingly, when you look at the total range of movement improvement they get, they've only achieved an average of 22% of that by the 3-month mark. So we don't need to panic. This lady had range of movement to 90 degrees, lots of pain behavior, lots of protective behavior when she was trying to lift her arm up. But when I facilitated it, we could actually get about 120. Importantly, her external rotation was stiff, but she had just over 50% of the other side. So again, I'm not particularly worried at this stage. Now, again, if you look at the 6-month mark, then by that stage, you expect patients to have anywhere between an 80 and 89% improvement in their pain. So they will still have some level of pain, particularly associated with activity, but a significant improvement. Again, with this lady, it's going to be slower. Now, in terms of functional improvement, generally, again, they're around 80-90% of the way there by 6 months, and they get 78% of the total elevation improvement that you'd expect to get. But remember, that's in cohorts who haven't got any negative prognostic factors. Now, the key thing is 90% of all patients that have an arthroscopic cuff repair are satisfied at 6 months. That doesn't mean they don't think they're going to get any better, but at 6 months, they're happy with progress. And what's really important, if we follow them up for 5 years later, they are still happy and satisfied with their outcome. Now, as I said, there's some key things that we need to consider with this lady particularly. One thing that's interesting when you look at reports comparing rotator cuff surgery to other surgical groups, there is absolutely no doubt that rotator cuff repair is one of the most painful procedures. Similarly, as I said, women have more pain post-op, so they report higher levels of pain and they are slower to respond, so you can increase those timescales that I discussed. Diabetics have worse outcomes. Interestingly, smokers and people that are obese, think of metabolic inflammation, think of that increase of inflammatory, pro-inflammatory cytokines. Again, what's interesting is they don't do as well and they have higher levels of pain, but they actually plateau earlier. A lot of our rotator cuff repair patients actually can improve for up to a year, and in some studies up to 2 years, which is really positive for patients. Maximum improvement by a year, but still some scope for improvement. Interestingly, some of these patients who smoke or have obesity, it would appear that they plateau earlier and don't get such good outcomes. The other thing that's associated with poor outcomes is pre-op stiffness, and also people going back to a heavy job. So again, if people go back too soon and start loading too soon, again, that seems to slow down their recovery and give them more levels of pain. And then the final thing to consider, certainly in terms of persistent pain, is mental health and psychosocial stress. So it's well demonstrated that if you look at things like the mental component score, the mental component score of the short form 36, and also things like the hospital anxiety and depression score, that scores on those are more highly correlated with the amount of pain somebody has with a rotator cuff repair than any structural feature of that tear. And again, when we look at those mental health parameters or psychosocial factors, they have a hugely stronger association variation and explain about 67% of the variance in patient self-reports compared to some of the physical things that we can that we can measure. So it's fascinating again, isn't it? This real message about the relevance of psychosocial factors. So what can we learn from this lady? I've shared you a lot of information with you about what the expected outcomes are, but remember they're the mean. And again, the confidence intervals are quite big, so there is a lot of variation. This lady is going to be on the worst side of those outcomes, so she's going to be slower. So meeting her at this point post-operatively, she's actually doing well. We don't necessarily expect there to be a significant improvement in her pain at this stage. The fact that passively she's got reasonable range and she's not lost loads of external rotation is really, really positive. But what this really highlights, and one of the things I've talked a lot about, as I say, over the last week, is if we fail to prepare, we prepare to fail. When I asked this lady what her expectations were, she said, well, I thought my pain would be much better by 6 weeks. I was told I'd be able to get back to work by about 8 weeks, and there's no way I'm anywhere near that at the moment. The doctor said I'd be fine, and I don't see how I'm going to be fine. And of course, it's, well, what do you mean by fine? And for the patient, that means getting back to everything they want to do. The surgeon means you're going to have good range of movement, your pain's going to be a lot better, but you're probably going to need more time for progress. Now, nobody's at wrong there. It's just really important when we meet people immediately post-op, particularly if we've not been able to see them pre-op, so we're inheriting them after their surgery, that we invest time in understanding those beliefs, those concerns, their expectations. Because if there is a real mismatch in how that recovery is likely to be, it's really important that we address that from the outset. It's probably not unsurprising to know that this is why pre-op groups are so useful and actually set our patient up to succeed, so that actually we could use questionnaires. There are studies looking at using questionnaires to actually assess patients' expectations of the surgery as a way of having then a conversation to challenge those expectations, because we know a mismatch in those things sets our patients up to fail. So maybe that's something we need to think about, that we need to be asking that more specifically as a question in our pre-op clinic. Certainly it's something I know the team do at the Liverpool Upper Limb Unit, where I've been very lucky to work for so long, but also understand a patient's understanding of what's going to happen, and the fact that, you know, they are going to have pain, and actually that's normal, and it's your body's chemical cabinet helping to heal that surgery and give you the best outcome. So we're really well placed to reframe that for patients. But equally, if we meet somebody pre-op, we can talk to them about the usual outcomes and highlight the factors relating to them that are likely to affect it. And then importantly, that shines a light on the things that potentially they can influence. This lady needs some help and support. She needs some time out. Yes, her explanation and understanding is going to help, but she needs to appreciate the impact of those psychosocial factors and all the other things she's coping with on her pain sensitivity and her tissue health. We need to talk to her about medications and her sleep. And again, they're conversations that are better had before surgery rather than afterwards. Now, it's really awful. Sorry, not awful. I'm going to come to your questions in a minute. I'll be right there. It's really interesting when we look at pre-op groups and pre-op education that actually often, if you then ask patients how much they recall from the consenting process and the information they've been given about their surgery, their recall is really poor. And they, in some studies, have shown they only actually remember about 25-30% of what they've been told. Now, it's absolutely clear, again, from some small number studies, and actually mainly done in the lower quadrant in knee arthroplasty and similar procedures, that actually if you give patient access to multimedial tools, then that can improve their preparation. Now, in the shoulder, we've got the fabulous Shoulder Doc website, which has all sorts of information for patients about surgery. We have a lot of the industry websites that, again, have lots of great information for patients. So it is out there, and it's really useful to sign patients to if their operation is on there. There's also apps now, the My Recovery app, where surgeons and physios can communicate with patients. So there's a big join up and making sure we're all giving the same information. So with this lady, she had pre-op cervical spine issues. We know, one, that makes her more likely to get a frozen shoulder. So we're going to keep a close eye on her and try and manage her pain and do something to involve her neck in her rehab. Secondly, she's got a lot, and we also know that that's correlated with higher levels of pain. She's female, correlated with higher levels of pain and slower recovery, as is the cervical spine involvement. lots of psychosocial stress in her life. Again, that's going to impact her recovery. She's not exercising. She didn't have a relatively long history pre-op, but a long history of neck problems. And obviously she had high levels of pain pre-op. Again, that's an associated factor with struggling more post-operatively. So as you can see with this lady, lots and lots of different things that potentially set her up, not to fail, but just to have more pain post-op and take longer to recover. So actually what I did at the end of this session was actually reassure her that she was on target, she was doing well, and highlight to her the things that essentially we can do to help support that recovery, but not missing the elephant in the room of all those lifestyle factors, that psychosocial stress that actually could be contributing to those things. So I hope that was useful. I think it's just, this is where the evidence can be a right pain, can't it? And so often papers come out saying that nothing we do works, not really giving us any way forward. But what I love about the outcome research, we're collecting our own data, or we were when I was working at the unit, but collecting data is part of everyday practice, because that way we can compare our outcomes with what's published there in the literature and see the kind of effect of changing our rehab or those interventions. So I hope that gave you some kind of useful bits to reflect on. Now, let's have a look. Hi, Jane. How Tim? Tim's got a question for me. So does gravity play a role calling the cuff to stretch and pull abnormally during sleep? So Tim, it's really interesting. I think there's been so much evidence There's been lots of research looking at, is there an optimal sleep position? Can you do things to make life easier for your shoulder? And actually, there's one paper that looked specifically at arm above head, arm down by the side, lying on your side, lying on your back. It makes absolutely no difference in terms of your risk of developing shoulder pain. So in terms of gravity, the reality is our bodies are robust and resilient. We're designed to deal with gravity, and the effect of gravity is actually greater during the day than it is when we're lying down. So I think the key thing is, actually, we don't need to be vigilant about postures or positions, because they don't really make a huge amount of difference. And I think that's a powerful message. Now, in a post-op patient, of course, it makes a difference, because if we get them to position their arm in mid-range with some pillows where pressure on the joint is least, tension on the tendon is least, in front of their arm, again, because that takes tension off long-headed biceps, which is often a bit grumpy, and with pillows behind them so they don't roll onto it at night, then of course that's really useful advice. But in terms of a general population or people who've had shoulder pain, the key thing is they're comfortable. But I don't think we need to worry too much about those effects. But thanks for the question. And Jane says, the patient's chemical cabinet. Yeah, I love that. It gives them a very positive message about their body, and that actually the pain is a sign that things are trying to heal and get back to normal. So again, we're so well placed to put a positive frame on our patient's pain experience. So guys, that was our first Facebook Live for a while. So I'm hoping to be here every Monday at 7:00. One of the reasons I've kind of changed how I'm working is so I've got a little bit more time to do a bit more reading, a bit more researching, a bit more course prep, and treat a few more patients, so that, I can really bring lots of case studies to you and share my experiences. And as ever, it's just about sharing shoulder knowledge and really kind of making people aware to reflect on their practice and think of all the things that we can do better for our patients. So guys, thank you so much for joining. I hope you've enjoyed it. I'll post a link to those 3 key papers on the Facebook page if you're interested in reading anything further. But otherwise, I'll look forward to seeing you next Monday. And don't forget to let us know if there's some key things you'd like me to cover in the future Facebook Lives. Bye for now. And thanks, Jane. I'm hoping that's the case. Otherwise, for now, enjoy the rest of your Monday evening, and I'll look forward to seeing you next Monday. Bye for now.